Hello to all of the listeners on the other end. I can see that there are a few familiar names and plenty of people that I don't know. For those of you who don't know me, you can call me Bron. I'm a new nurse practitioner at Austin Health, and you can see my email address there on my first slide. It's also on my last slide as well. Today I've chosen to talk about thrombotic stroke and atherosclerosis because I've learned a lot about this subject and realise that I still have much more to learn. As usual, I've got too many slides, lots to get through, so I'll move pretty quickly, and I think it's probably best if I leave the questions until the end. You can certainly write them down as we go. And if we run out of time to answer your questions, please do feel free to email me, and I'll do my best to answer you in a reasonable time frame. So I'm just going to go through a case example, look at the pathogenesis of atherosclerosis, and talk a little bit about the evidence for carotid endarterectomy surgery and some clinical considerations. So we're going to, review a case. My case example is that of a 78-year-old man. He's a retired builder, lives with his wife in the house that he built himself. He's completely independent with his ADLs, drives a car called Sonia. She's a 73 LJ Tirana two-door, and we got talking about this because my grandfather used to drive the same kind of car. He's a passionate gardener, cares for his grandchildren, and in short, he's the energetic patriarch of a large Greek family. So he was born in Greece, been in Australia for many years. He's an ex-smoker, quit 5 years ago, but got a 50-pack year history. And in terms of alcohol, he reports that he drinks 3 or 4 standard drinks a day of his own homemade grappa. He's got ischaemic heart disease, which is stable. He did have a heart attack under the age of 50, though, and had coronary artery bypass graft surgery, but has since been stable for a long time and discharged from cardiology follow-up. He's got a bit of blood pressure, dyslipidemia. He's certainly got central obesity with a BMI of 34 and a waist circumference well above the recommended 95 centimetres, I think it is, for men. In terms of medications, he's very good with taking his medications. He's on aspirin 100 milligrams daily and simvastatin 20 milligrams daily. And he tells me that he's never been on any antihypertensive medications, which doesn't seem quite right. So this morning, the morning that I met him, he woke up at 7:30 feeling perfectly well, picked some roses from the garden, made coffee for his wife. While he was shaving at 20 minutes past 8, he suddenly had an onset of, while he was looking at the mirror, he saw the left side of his face drop down. His left arm was heavy, he couldn't lift it up to his face, and his speech was slurred, muffled and mumbled. Within 3 minutes, the symptoms resolved completely. So he called his eldest daughter and asked for her advice. And she attended the house within 5 minutes. While they were sitting at the table, he had a recurrence of his symptoms at 9:15, witnessed by the family. He slumped to the left, his left side of his face dropped down, his left arm was weak and his speech was slurred. So his daughter bundled him into the car and they set off for the GP. And while they were on their way, the symptoms again resolved completely. So he arrived at the GP at 9:30 or thereabouts. And while he was there, once again, he had sudden onset of left weakness, slurred speech, and this was seen by the GP. And at this point, the ambulance was called. So the paramedics got there very quickly and diagnosed acute stroke. They checked his blood sugar and blood pressure and put the 12-lead put the ECG on and transported him signal 1 to the nearest hospital, which was our hospital. They didn't provide us any pre-notification because on the way he was getting better. His symptoms were improving, but they did put in a cannula. From the triage nurse immediately called a stroke call She triaged him as a Category 2, allocated him to an appropriate cubicle, a resuscitation cubicle, and noted that his neurological symptoms were largely improving. He had his left arm weakness and facial droop had resolved completely, but his speech was still a little bit slurred. He was stable despite being hypertensive and a little bit hyperglycemic. And when the stroke team arrived a few minutes later from the end of the bed, he looked alert. He was eyes opening, answering questions, certainly no airway risk. He was moving all of his limbs. He was very tearful and very anxious. In terms of his GCS, he was orientated in time and place and person. He was appropriate and cooperative, seemed to be attending to both the left and the right, and there was no evidence of speech trouble at that point. So we did an NIHSS stroke screen, and he scored 1 for dysarthria. So I'm interested to know what you all think. Feel free to type in. I can see your responses. Based on his history and brief examination, can you localise the problem here in the central nervous system? Do you have any differential diagnoses? And what do you think should be the immediate investigation? I thought that it was a focal brain problem and probably arising from the right anterior hemisphere. I thought that it was most likely he was having cortical transient ischemic attacks or even ischemic stroke. His symptoms haven't fully resolved at this point. And the reason I say cortical is because his face and arm seem to be involved more than his leg. But it could have been also equally could have been capsular warning syndrome, so pure motor lacuna stroke or TIAs, which often have this sort of stuttering onset, on off. Could have been intracerebral hemorrhage, and there's no way to differentiate between ischemic stroke and hemorrhage without a CT scan, but seemed to be less likely given that his symptoms were fluctuating so much and largely seem to be improving at the moment. There are some other things that it could have been. Could have been small subarachnoid hemorrhage causing what is sometimes known as amyloid spells or simple partial motor seizures. So we took him off for an urgent CT brain scan, and we did a non-contrast CT brain scan and a CT perfusion scan. And I'll go through some of the images now. I've had to cut a few out, so I've given you every second slice on the non-contrast scan here, bearing in mind that I think we're looking at the right anterior hemisphere. I'm just wondering if there's anything that you think you can see there. Take my word for it that there was no evidence of hemorrhage, and so we went on to do a CT perfusion scan. And this is the mean transit time, where you probably notice that there is a little bit of difference in the right hemisphere compared to the left hemisphere. Usually when we see mean transit time deficit indicating a penumbra on the CT brain scan, we should expect it to be very high, very slow transit time. But this is moderately high compared to the left hemisphere, and it seems to be including the entire hemisphere on the right-hand side. This is the cerebral blood flow, and seems to be fairly symmetrical to my eye. And cerebral blood volume, much the same. So pretty symmetrical between the left and the right hemisphere. No evidence of, large established infarct, and maybe some increased mean transit time. So here are the intracranial angiographic pictures, and this is the left MCA here, left ICA coming into left MCA, and right ICA coming to right MCA. I will throw a few of those there. And whilst this doesn't look completely the same between the M1 and the M2 portion of the artery, we think it looks fairly patent there. So in summary, we've got a 78-year-old man who's completely well. He's had a presentation of acute stroke or multiple TIAs, and he's less than 4.5 hours from onset. But his NIHSS is currently 0. He's completely resolved by the time he gets out of the CT scanner. His CT brain scan rules out intracerebral hemorrhage, and I don't think you could see it very well on the images that I showed you, but it's possible that he might have quite a chronic-looking, very small right anterior external watershed territory infarct. There's very subtle increased mean transit time in the right frontal lobe, normal cerebral blood flow and normal cerebral blood volume. And we wondered if there might be a high-grade stenosis in the right internal carotid artery, which we haven't viewed with our angiography, to account for the mean transit time abnormality. There was a possible short segment filling defect in the right M2, but the comments from the radiologist was that they thought that was artifactual due to some dental work that he had there. But there are no contraindications to thrombolysis, no history of bleeding, no recent surgery, stroke, myocardial infarction. He's not anticoagulated. And I wonder what you would do based on his examination, imaging and medical history. Would you treat him with intravenous thrombolysis or treat him with antiplatelet therapy? And what would be your immediate investigations and urgency? So our decision was to not treat him with thrombolysis. He'd completely resolved and his NIHSS was 0. He didn't have a clear vessel occlusion, and he seemed to be, staying well at this point. We did think that we should upgrade his antiplatelet therapy. He was taking aspirin previously, and he'd been very diligent with taking his aspirin. So we thought we would sort of up it to clopidogrel, 75 milligrams daily, and we thought he should probably be started on some antihypertensive therapy. So our choice was perindopril, 5 milligrams daily, but we wanted to be fairly conservative with his blood pressure aims in the next 24 hours, and we were really happy to accept a blood pressure that was anywhere less than 180 on 90, and then we would review it after 24 hours. We also thought we should maximise his statin therapy, so instead of simvastatin, 20 milligrams, we're going to increase that to atorvastatin, 80 milligrams. And in terms of his care plan and further investigation, we wanted to admit him to the stroke unit as soon as possible, and at our hospital that would generally be well within 3 hours of arriving in the hospital. Give him care as per our stroke unit toolbox. We wanted an urgent ultrasound of his neck and intracranial vessels right away, today, now, which we have access to in our hospital. We wanted to make sure he had continuous cardiac monitoring, looking for atrial fibrillation, and that he had frequent neurological observations. And we did stress to our nurses to report any neurological change to the stroke team immediately, because we would again consider IV thrombolysis if his symptoms were to reoccur. And also a 12-lead ECG and some fasting bloods less urgently. So he went off for his duplex ultrasound after a couple of hours in the stroke unit, and that showed in the extracranial right internal carotid artery there was lots of calcification just beyond the very proximal segment of the right ICA. The velocities right before that very calcified area showed stenosis consistent with 70 to 79%, so fairly high velocities, and couldn't really see the rest of the ICA because of this calcification. On the left, he had a less than 50% calcified stenosis at the bifurcation. The vertebral arteries looked normal throughout the intracranial and extracranial portions, but they noted that there was cross-flow again across the anterior communicating artery coming from the left to the right. The middle cerebral artery velocities were normal where we could see them. There was retrograde right ophthalmic artery flow and anterograde left ophthalmic artery flow. So really indicating that there was probably quite a significant problem in the right internal carotid artery, probably beyond the area of calcification where it couldn't be viewed very well, meaning that the blood was flowing from the left side across to the right side. So we decided that he needed some further vessel imaging. We needed to get a better look at that artery to see what was happening there. And again, I've had to chop out some of the photos, but here we have the right internal carotid artery which traverses along here. This is the common carotid artery, And on my next slide, we'll see the area where it bifurcates. So just here is where it's going to bifurcate into the internal carotid artery. And you can see here that there is lots of calcium and a bit of a filling problem here, and also that the right internal carotid artery is not looking so good. It does continue up here, but the right compared to the left is very, very narrowed and not what we would expect to find in a normal cerebral vasculature. You can see it moving up. So our plan at this stage, while he was still symptom-free, was to refer him to our vascular surgeon colleagues and ask them whether they will consider doing a right carotid endarterectomy for him. And not really sure, but wanted to know what they thought was the best timing for that surgery. And so after the surgical list at 7 p.m. that night, he was seen by the vascular surgeons, who looked at the imaging and said, I think we need some more imaging. They wanted to do a formal DSA, and it couldn't be done for 3 more days. So in 3 days' time, on Monday morning, he was booked in for a DSA. And they really wanted to be able to better define the anatomy of that artery and define the degree of stenosis and occlusion, because it looked quite severe on the angiogram. The risks were explained to the patient and consent was obtained at that point. And here is his DSA angiogram on Monday morning. And the report says that there is a 99% occlusion of the right ICA and retrograde filling. So this filling that we can see here is coming from the external carotid arteries and the ophthalmic artery, and where it tapers off here at the base of the skull is where, beyond that, there was nothing more than a tiny string of contrast coming through. On day 4 of admission, less than 24 hours after his DSA procedure, he had a MET call at 7:45 in the morning for new left-sided weakness, onset at 7:20, witnessed by the nurse in the stroke unit. He was hemodynamically stable, although you'll notice that his blood pressure was much, much lower than it had been when he first came in, just with some perindopril given daily. The symptoms resolved completely within 5 minutes without any treatment, and the stroke registrar was in attendance at the time. But 15 minutes later, at about 20 to 8, they started again, and an acute stroke call was activated at that time. And so the stroke registrar and the neurologist were in attendance there, and they raised the possibility of seizure activity due to some left upper limb shaking, which you may have an opinion about. His NIHSS score was 6. He had a gaze preference towards the right. He had left facial weakness, left upper limb weakness, dysarthria, and some mild sensory inattention. So he went off for another CT brain and perfusion scan urgently. And I haven't showed you all the images, but here is his rapid, showing what Rapid thought was quite a significant area of infarct core, even though this was only taken 20 minutes into his symptom onset. And on the right-hand side, quite a large perfusion deficit, so 116 mils of mismatch there between what was thought to be core infarct and penumbra. So a very significant stroke. The decision was, of course, to treat him immediately with intravenous thrombolysis, 0.9 milligrams per kilogram, maximum dose of 90, 10% of the dose given as a bolus over 1 minute and 90% over 1 hour. And the symptoms resolved completely after treatment, back to an NIHSS of 0 at 10:30 a.m., which again seems a little bit unusual given that Rapid thought that there was an area of core infarct already on the brain scan. He had some follow-up CT imaging 24 hours after thrombolysis, and we organised for him, requested an inpatient MRI, which in our hospital takes quite some days to get. The decision was made to go ahead with the EEG, and we thought we better inform the vascular surgical team of the new stroke event and request an urgent review, because they'd felt that based on the DSA imaging that there was no intervention that would be helpful for that very severe stenosis of his right internal carotid artery. It was also thought that the risk of further stroke from that artery was fairly low, but clearly he was having another big stroke and had been lucky enough to resolve completely with alteplase. we decided to add aspirin back in to his clopidogrel and repeated an ultrasound of his neck vessels. And that was done straight away. So the extracranial right internal carotid artery was more suggestive of a complete occlusion at this time, so a progression from the previous appearance. The left was unchanged, the vertebral arteries were the same. There was still left to right cross flow across the anterior communicating artery, and there was velocity elevation in the proximal right MCA, and so that was suggestive of a stenosis in the right M2 or possibly an occlusion. They also noticed that there was increased flow from the right PCA, which they postulated could be collateral recruitment from the posterior circulation. And importantly, they saw some microembolic signal in the right anterior cerebral artery. So the vascular surgeons came back and they said, well, the right internal carotid artery is now completely occluded on the ultrasound, and there really is now no role for carotid endarterectomy. Maximal medical management was the recommendation, and that met with our understanding of the literature. This is his post-thrombolysis CT scan. So indeed, there wasn't core infarct in the area where Rapid had thought there would be core infarct. On day 5 of his admission, 36 hours after thrombolysis, while he's waiting for an MRI, at 5:30 in the evening, he had another urgent clinical review for new neurology. He now had dense left upper limb weakness with 0 out of 5 power. His facial droop, which had still been persistent following, I think had completely recovered after thrombolysis, was now quite severe. He had forced gaze deviation to the right, left hemisensory and spatial neglect. His right leg was weak and he was vague. He was not quite himself, orientated in time, place and person, but not his normal self. His NIHSS score was 16 and he appeared to be having a cortical right MCA and ACA syndrome. At this stage, his medical therapy had already been well maximised. There was some confab between neurologists about what further acute treatment or intervention could be provided, and another discussion with the vascular surgeons who felt that there was nothing that they could offer. We did do some follow-up imaging with CT and MRI, and unfortunately, at this point in time, he had infarcted a large portion, the anterior division of the right MCA and also the right ACA as well. You can see that there on that one slice of the MRI I've provided, and also that the time of flight angiogram from the MR shows that there's not normal flow in the right MCA. A very disappointing outcome. So he remained neurologically stable for the remainder of his acute care episode, but his NIH at discharge was 14 and his modified Rankin was 4. He was treated for a hospital-acquired pneumonia, likely aspiration, and discharged to inpatient rehabilitation on day 21. He undertook 66 days of inpatient rehab and was subsequently discharged to his home, where he was ambulant with a single point stick and no assistance, but did require assistance with just about all of his ADLs. He had dense left upper limb weakness. He was certainly less motivated than before, and the family noted some personality changes. He was never going to drive his Sonia again, and his modified Rankin, as I said, was 4. So, atherosclerosis. I'd always thought thrombotic stroke was sort of the more boring of the stroke subtypes, but this case in particular really made me want to look at atherosclerosis, about carotid stenosis and its cause of thrombotic stroke, and of the evidence for carotid endarterectomy surgery, because I felt at the time, and this was quite some years ago now, I felt that this it just wasn't fair that the evidence told us we couldn't provide surgery for this man, by the time we had the sufficient information for the surgeons, it was too late to do surgery, and our maximal medical therapy didn't prevent his stroke. It also highlighted for me the importance of recognising carotid plaque rupture, which I think is probably what caused his flurry of symptoms, and the importance, the high risk of early recurrence of stroke after a thrombotic type of TIA like this. So I learnt lots about atherosclerosis, and in terms of the pathogenesis, this paper by Falk in 2006 described atherosclerosis as a multifocal, smouldering, immunoinflammatory disease of medium and large size arteries fueled by lipids, which I thought was pretty poetic. I think some scientific writers really want to be novelists. So atherosclerosis is a pathological process causing disease of the arteries, and typically we see it affecting most the aorta, the aortic arch, the coronary arteries, cerebral arteries, and some peripheral arteries as well. We typically tend to think of it as an age-related disease, but there's no doubt that the process can be accelerated by other factors, and in particular, people who've had radiation therapy for example, nasopharyngeal carcinoma is an example that we see not uncommonly in practice, where head and neck radiotherapy causes a severe acceleration of the atherosclerotic process. And there are other factors that can accelerate atherosclerosis. For example, if you put a stent into an artery, we'll tend to see that area of stent will be further, the process of atherosclerosis may be accelerated in that area. But I was interested to learn that these atherosclerotic changes occur in the artery over a lifetime. So even in the childhood years, the beginning of atherosclerosis can be demonstrated with development of fatty streaks in the arteries. So for young people, children and teenagers who've died from other causes, during autopsy they can see that there are already artery changes happening, even in healthy individuals. So from even in young childhood, there's development of fatty streaks, and in the teenage years, sort of 15 to 24, you start to see a thickening of the artery, of the intima of the artery, and xanthomas. And then from the fourth decade of life and beyond, that progresses to what's described as fibroatheromas with thin fibrous caps. And these can tend to rupture in people with advanced atherosclerosis. During autopsy, we can see plaques that have ruptured and healed, and plaques that have become hard and calcified. So the American Heart Association actually classify the lesions with using sort of histopathology, so taking specimens of the artery, and they sort of grade them according to what you can see. So a grade of 0 is a normal artery with no intimal thickening. Grade 1, we start to see macrophage foam cells, which contain lipids. They have no extracellular lipid and variable adaptive intimal thickening. At grade 2, there are numerous macrophage foam cells, which are often layered with particles of extracellular lipid as well. By grade 3, there are again numerous macrophage foam cells and pools of extracellular lipid, but without any well-defined core. By grade 4, again numerous macrophage foam cells with well-defined core of extracellular lipid, with a luminal surface covered by relatively normal tissue. By grade 5, they have this all the same with a with a fibrous cap. And at this stage, they start to have vascularization or calcification of the intima. And then at grade 6, you have all of the above, plus a sort of defect of the surface of the plaque, with sometimes hematoma, hemorrhage, or thrombosis. So a complicated or ruptured lesion. And here's a picture of the. So this would tend to, previously the diameter of the artery would have been like this, and then over time you start to get this intimal thickening. Here is a now this long arrow is what they call a soft lipid core. So that's sort of all just mucky soft lipid in the middle there, and this short arrow here is where you can see that the intima has become quite thickened. So lots of factors influence the process of atherosclerosis, including, most importantly, the advanced age. So more and more as we age, you can see these changes occurring in the arteries. Don't really understand why males are more affected by atherosclerosis than women are. There's a lot of attention to endothelial dysfunction, and also lots that you can read about oxidative stress. So I think that we probably understand quite well that processes like hypertension and diabetes all cause damage to the endothelium. It's thought that the first process that happens is that nitric oxide is not able to function in its normal way, and this is, in turn causes sort of oxidative stress to the inner lining of the artery. Lots of people have atherosclerosis, but it's well recognised that dyslipidemia is a real driving force for atherosclerosis. So particularly people with high serum LDL and low serum HDL are at risk of developing atherosclerosis. There are genetic factors. People with family history of atherosclerosis are more likely to have it, and also more likely to have more complex plaques. But there has been a huge amount of attention in the last 20 years or so to the role of inflammation in the immune system on how plaque behaves, and particularly what causes plaque to change and rupture, causing problems. Smoking is a huge risk factor, and again refers back to the damage to the endothelium of the artery. There is evidence to say that people who have an increased serum homocysteine will also be more at risk of developing atherosclerosis, diabetes, a diet high in saturated fats, and the role of obesity in atherosclerosis and in how the body processes lipids. The concern, and this slide, which is taken from Up to Date, refers specifically to atherosclerosis and the role of LDL in coronary atherosclerosis, but the process is, from what I understand, the same throughout all of the arteries of the body. And the fact that there is an oxidative process that goes on that affects LDL to cause, so first of all, development of fatty streaks, dysfunction of the endothelium, and inflammation. And when the plaque is not calcified, when it's kind of soft, or when the fibrous cap is damaged, then this is what seems to lead to plaque rupture. And interestingly, we can develop atherosclerosis slowly over many years to the point where an artery is completely occluded altogether, and particularly where there is a collateral circulation, that may never cause any symptoms or any problems. So there is more than just the atherosclerosis that results in the stroke or the heart attack, and that process is thought to be superimposed thrombus. So looking more specifically at atherosclerosis of the carotid arteries, it's most often focused at the bifurcation, predominantly at the distal common carotid artery and proximal internal carotid artery, so just exactly where we saw our patients' atherosclerotic plaque in the very distal CCA and proximal ICA, sometimes proximal CCA, and sometimes at the terminal ICA. Anatomical differences can make imaging tricky, so often the bifurcation is situated at level, I think the textbooks will tell you, at level C3 to 4, but that's really only the case for about 55% of individuals. Sometimes the bifurcation is quite high, just underneath the skull base, or even quite low. And when it's particularly high, that makes it very difficult not only to image with Doppler, but also for the vascular surgeons to be able to access. The severity of atheroma is often asymmetrical, which is a little bit fascinating, and we don't understand why that is. So in smaller arteries where there's sharper angles, where the flow bifurcates more severely, that's where you tend to get more severe atherosclerosis. And whilst it's usually a very, very slow process that occurs over many years, it can also be seen to develop very, very swiftly over months. And again, we don't fully understand. We know some of the factors that will result in accelerated atherosclerosis, but we don't really understand what causes this sudden acceleration of the disease. Smoking and presence of diabetes or poorly controlled diabetes will tend to result in swifter progression of the disease. I'm just showing you here the picture of the common carotid artery here, distal common carotid, proximal internal carotid, and we see this typical pattern. In fact, sometimes you'll see it all around this area. And another thing to notice here is the diameter of the vessel. So as well as just the plaque developing on the inner lining of the artery, there's also a sort of what we call, with the intimal thickening, the artery itself becomes more sort of bulbous in this area as well. Is the common carotid artery in the neck, the internal carotid artery, which if you're looking at an angiogram is the artery that is the branch off the common carotid that does not have any other branches. So the external carotid artery does have branches, and that's the easiest way to follow it along an angiogram. And here is the vertebral artery going through the foramina in the cervical spine. This is a picture of the aortic arch, internal carotid artery, vertebrals, basilar, PCAs here, ICAs coming into the MCAs, PCOMs for those of us who have them, anterior cerebral arteries on the left and right, and the anterior communicating artery here. And this shows where we tend to find atherosclerotic lesions and their sort of frequency. So most often where they're dark purple, and less often where they're light purple here. And so here's where you can see that there's a bifurcation here. So we see atherosclerotic disease there in this tortuous part that comes in and travelling through some of the small bones of the skull. Lots of atherosclerosis tends to develop there. Here at the tip of the basilar, in the vertebral arteries, and of course in the aortic arch as well. And so just a nice little diagram sort of illustrating the fact that when the internal carotid arteries, the main supplies of blood to the anterior hemispheres of the brain, when they're not able to supply their normal territory, then there are collateral circulation pathways that can develop, and it's thought that the development of these collateral pathways will mirror the severity of the stenosis. So if you develop your carotid atherosclerosis slowly over many years, you're more likely to have developed some collateral pathways around them. However, the older you are, the less robust your collateral circulation will be. And if, of course, you, for example, rather than developing a slow progressing atherosclerosis, if you dissect your artery and then it thromboses and fills up completely, there may be no collateral circulation pathways around the problem. So the link between carotid atherosclerosis or stenosis and occlusion and embolism and resulting in brain ischemia has been recognised for more than half a century. We know that symptomatic carotid artery disease accounts for, let's say, 20% of all focal ischemic brain lesions, of all ischemic strokes, and that smoking increases the relative risk of stroke when there's atherosclerosis by as much as 50%. And so you've all seen this division of stroke subtypes. We've got cardiac embolism, strokes that we don't know the cause of, small vessel or lacuna strokes, hemorrhages, the unusual causes of stroke like random arteriopathies, vasculitis, dissection, other sorts of problems. This is the portion that we're talking about, the atherosclerotic or thrombotic strokes. We know that people who have symptomatic stenosis of the internal carotid artery and who have a TIA or a stroke are at high risk of an early recurrent stroke. And our patient demonstrated that very nicely, unfortunately. So the estimated annual stroke risk for these patients is as high as patients with, with atrial fibrillation and a high CHA2DS2-VASc score without anticoagulation. So these are high risk of stroke. The implications are great, and the prognosis is actually relatively poor. So these are, they can tend to be more disabling strokes with very large regions of ischemia, certainly compared to lacuna infarcts, and certainly high risk of malignant edema requiring sometimes hemicraniectomy surgery. The patients tend to be slightly younger than those in the atrial fibrillation cardioembolic group and are often smokers and have concomitant coronary artery microangiopathy and disease. The mechanisms that cause stroke, so if there is a complete occlusion below the circle of Willis, sometimes there can just be inadequate collateral pathways or inadequate flow from other adjacent cerebral arteries, and these are usually the catastrophic type of strokes that result in the full tachy syndrome and malignant edema. But there can also be perfusion failure, and there was a lot of discussion about this particular case as to whether when our man had his first inpatient stroke and his perfusion imaging looked so very bad, that perhaps this was actually a hemodynamic stroke. So because his blood pressure was so much considerably lower than it had been previously, perhaps there was just a failure of perfusion because not enough blood pressure essentially to perfuse beyond that area of stenosis. And of course then there's also artery-to-artery thromboembolism, where a ruptured atherosclerotic plaque with superimposed thrombus over the top of it, and some of that thrombus will sort of embolize to the distal vessels, resulting in an occlusion further down. Do you say downstream or up? Further downstream, and so those typically result in a Pachy syndrome or a TIA or amaurosis Fugax. There can be ocular infarction or ischemic optic syndrome, anterior carotid artery infarction, ICA embolism, anterograde extension. And this is, I think, what happened to my patient was that the thrombus extended up to include the ACA as well. So where there had been cross-flow coming from the left side to the right side across the anterior communicating artery, the thrombus actually propagated to the point where, because as you know, a bit of thrombus will propagate more thrombus, to the point where there was no longer any, that pathway across the ACOM was no longer able to supply the anterior circulation on the right, and so he infarcted his ACA territory as well. And of course there is also, when we see these really severe, particularly multi-vessel severe stenosis, chronic small vessel ischemia and dementia. So I've already alluded to the fact that we really wonder and want to know more about the role of inflammation and the immune system on plaque destabilisation. It's very well recognised, still not very well understood. And many atherosclerotic plaques never become symptomatic, even when they cause a complete occlusion. Previous to understanding this inflammation process, atherosclerosis on its own could be described as an indolent process. So that by itself not really causing any problems. It's the rupture, the thrombus that seems to that causes the strokes and the heart attacks and the problems. Rupture-prone plaques seem to be characterised by a lipid-rich core with a thin fibrous cap. There's angiogenesis, inflammation, outward remodelling, and obesity has been linked as a modifier, an inflammatory modifier to atherosclerotic events. Again, we don't have a good understanding of the role of obesity in inflammation either. A little bit of word on carotid endarterectomy. So this procedure, this surgical procedure to clear out the pipes in the neck, first introduced in the 1950s, and the early experience of this surgery was pretty variable, and in fact randomised controlled trials published sort of before the 1990s were, apart from being widely criticised as being methodologically pretty flawed, they were also not necessarily positive trials. But then there was 3 trials in the 1980s, randomised controlled trials comparing symptomatic carotid stenosis surgery with carotid endarterectomy and comparing that with with medical management, which, important to remember, at the time did not include statin medications. So maximal medical therapy back in the 1980s wasn't as good as a maximal medical therapy now, but nor was the technique for surgery either. So our vascular surgeons are extremely good at performing this surgery. It's fairly straightforward in a lot of cases, and the operative risk for most patients is really quite low, and certainly less than 6%, which is the sort of quoted cut-off point. So in all of these trials, patients were basically categorised according to the degree of stenosis. So the categories were a little bit different, and in fact the methods for measuring the degree of stenosis were also different, but the patients were sort of either mild, low-grade stenosis, let's say 0 to 30%, moderate stenosis, 30 to 50, I think that would probably still be considered mild these days, 50 to 69, 70 to 79, 80 to 89%, and then stenoses which were very, very high grade, sort of 99% or occluded. I looked at these trials. It's nothing like reading a comparison of, for example, our endovascular clot retrieval trials now, where all trial methodology is pretty similar, where they all compare sort of an intervention with another standard sort of therapy. It's much more difficult to elucidate the kind of to compare. The outcomes were measured differently, the degree of stenosis was measured differently, so I thought one thing that certainly struck me reading these old trials was that we've come a long way in trial methodology. But ultimately, what I found most helpful was the post-hoc analysis of these trials, which inform our clinical guidelines now. And this is a post-hoc analysis just looking at outcomes, stroke or operative death, ipsilateral, so stroke on the same side as the stenosis, and any operative stroke or operative death, disabling or fatal ipsilateral ischemic or operative stroke and operative death. And so this is the patients at the top here with near occlusion, and in the thick black line is the patients with surgery, and the thin grey line is the patients with medical therapy. And you can see that this is proportion of people who had an event. So as we go forward in time. There's usually a bit of a sharp rise in the first few days because people do have strokes and death with surgery, and as time goes on, this is about how many people had an event over time. And so in the near occlusion group, you can see that there isn't a lot of difference in any of the outcomes. So when the stenosis is very, very high grade or nearly occluded, then there isn't a lot of benefit. But in the 70 to 99% group and in the 50 to 69% group, there's a significant difference in the number of people who had an event. So people on medical therapy had more events than people in the surgical group. When it came to the lower grade stenosis, so 30 to 49 and less than 30%, again, the benefit of surgery not quite so obvious. And this is just showing really the same data in a different kind of way with a absolute risk reduction above the line here. So this was negative risk reduction for people with a very low grade stenosis, less than 30%. And all of these are symptomatic. I haven't presented any of the data here about asymptomatic stenosis. You can see the people who have the most benefit, the most risk reduction, are those in the sort of 60 to 69, 70 to 79, 80 to 90, 89 and 90 to 99%. But again, those people with the, like my gentleman, with the near occlusion or the 99% stenosis, really not receiving that much benefit. And again here, just looking at another outcome. So ultimately, we know that surgery is of some benefit for patients with the 50 to 69% symptomatic stenosis, but very highly beneficial for those with the 70% symptomatic stenosis or greater, but without near occlusion. I wonder if we had have caught our man a little bit earlier, if he had have had perhaps his DSA on the day of his presentation, if he would have had certainly by the appearance of the Doppler, his stenosis wasn't as severe in the first days of his admission. Just to draw your attention to the fact that there are clinical guidelines in existence. I don't believe that these have been updated since 2011. I couldn't find them if they had. I know that it's certainly an ongoing area of interest, of course, and that carotid artery stenting has been looked at. I haven't presented any information about that. Carotid stenting should really only be considered, I think, for people with very high operative risk or for whom surgery is not appropriate due to anatomical issues or high operative risk. Of course, and I've just pointed out the American guidelines here. They certainly identify carotid artery stenting as an option, but in our centre, we do not perform carotid stenting routinely at all, although you may see it happen more and more often now with endovascular clot retrieval when the operator the interventionist needs to gain access to that artery urgently. So very quickly, clinical considerations for these patients. So anybody with a symptomatic greater than 50% carotid stenosis is high risk of early recurrence. That thrombotic strokes arising from these type of atherosclerotic stenoses can be catastrophic, and that crescendo TIA, like what my man had, warrants urgent vessel imaging, so not going home for the weekend to come back on Monday to have a Doppler. They need to have their vessels imaged today, now, and if that means a CT angiogram in our organisation, that's what would happen. Cautious BP reduction, particularly in the acute phase and also when there's bilateral high-grade stenosis, because obviously it takes a lot more pressure to get through those blockages. And in terms of timing, I didn't really mention it, but generally recommended within 2 weeks of the event, and after 6 months the stenosis is considered asymptomatic. Patients are a little younger, often smokers, often have heart disease, and that aggressive risk factor modification is really important. So smoking cessation has to be addressed. Physical activity is important. Nutrition counselling is important. Aggressive management of dyslipidemia, aiming for LDL less than 2, less than 1.8. Management of hypertension is certainly as a primary preventive factor in management of diabetes. And that genetics do play a role in atherogenesis, progression and rupture. That's all I've got to say. I've only left us about 5 minutes worth of questions, but I'd love to hear them if anybody's got any questions. From Sasha, in hindsight, given his stenosis, should his BP have been reduced at all, and do you think the thrombolysis had any role in emboli coming from the plaque? I think that in terms of thrombolysis causing emboli, it's entirely possible. It was 36 hours afterwards that he started to develop symptoms, and that would probably be a reasonable time frame for, first of all, the thrombolysis to cause further bleeding of the carotid plaque, which would then, after some time, clot, and then would be an appropriate time frame to cause emboli from that area. Yes, it certainly could have. I think it was the appropriate treatment to give based on the presentation and the imaging. This was before the days of endovascular clot retrieval, and I should also point out that, in fact, whilst I showed you a perfusion image, I didn't show you vessel imaging, and there was no intracranial vessel occlusion at that point in time. So had that case presented to me today, would have had better and more information, and probably would have been looking at a situation where this patient was taken urgently for some sort of intervention, whether that be endovascular clot retrieval. I think that he certainly warranted treatment, and it's hard to know what would have happened if we hadn't given him thrombolysis. And hello to Nellie in Ballarat. Stars in Ballarat, thrombolysing patients in the emergency department. That's great. What I really wonder for this patient is whether or not there was a role for an urgent carotid endarterectomy on the day of his presentation, and I certainly think that I would have been pushing for a same-day DSA, and I wonder, I wanted to present information about the different modalities of imaging of carotid stenosis, because there's lots and lots of evidence about what's most effective, what different information you get. Here we're lucky, we have very, very quick access to Doppler, ultrasound of the neck vessels and also of the intracranial circulation. We've got some fabulous members of our team who do that all day, every day, and that's really useful information for us. So we have the luxury of multiple imaging modalities quite quickly. We don't do a CT angiogram of the arch to vertex for every one of our acute stroke calls, although again with clot retrieval we're doing more and more of that now, and the reason we don't do that is because we do have such good access to other modalities of imaging. But I wonder, you know, how many modes of imaging do you really need before you do some surgery? And sometimes the vessel can appear to be the 99% or string sign occluded, and in fact they describe it as being distal vessel collapse, and I probably don't really understand the physics of that as well as I maybe could or should, but I think, yeah, this patient was clearly at a very, very high risk of stroke, and it was very, very sad to watch him stroke the way he did. And I guess there's no more questions and it's time up. So thank you very much, everybody, for your attention. And as I say, happy to take emails.